I want to welcome everybody to Friends Talking. And we have a topic on prostate cancer today. We're actually also doing this live on YouTube. So I've asked a good friend of mine, colleague from the VA, a urologist, Robert Avelayamont, and I'm probably butchering his name right now, but good colleague. He's helped me with my prostate issues, and I wanted him to do a short lecture on prostate cancer. We know that that's very prevalent in our community. And so I asked him to come on actually a couple of weeks ago. So I'm glad he's here, and he'll give an introduction to himself, and then we'll do the presentation. I think he's got a slide presentation, and I think he wants to do it where we may have questions and answers in between. So we've got a live chat. You guys can do questions on there, and we'll be looking at that. And try to invite a number of people, friends and family, to the discussion this afternoon. So I'm glad everybody is on board, and we've got a number of people here, and I think you guys will enjoy this topic. What I'll do is, Roland, are you available to pray?
Sure, no problem.
Yeah, why don't you go ahead and pray, and then we'll have Doc open up with the presentation.
Okay, let us pray. Dear Father, we thank you once again for the opportunity to come together as men and to discuss this particular topic that has affected so many of our fellow brothers around the world. We ask that you will be with the doc as he gives us insight and gives us wisdom, and that we'll be able to take these lessons and be better informed and understand this particular disease. Guide us now, we pray, to your son's name. Amen.
All right, Doc, you can go ahead and take charge. And if you want to just go through with the presentation, or if you want to take questions and answers, it's up to you.
Yeah, I thought, thank you for the invitation. And I thought we would just take questions as we go. I need to just start off with a number of comments. It's a privilege to be here. I can elaborate on that. It's a privilege to be a doctor. And it's a very sensitive topic, a private area. So, I take everybody's trust very seriously. I can be kind of long-winded and very opinionated, and I want to be careful what I say so as not to contradict things that other people believe are true. We all have our backgrounds and our biases. So, and I apologize for the slides aren't being visualized properly, but this is what I threw together, and the best I can do, I guess. So yeah, Avelayamont, Robert Avelayamont, it's a French name. And just so you know who I am, I was actually born in Holland with a French name, so people move around. 52 years old, teenage kids, been married 22 years almost. Grew up in Southern California, college there, medical school in Ohio, and spent most of my adult life in Connecticut, training in Providence, Rhode Island. I mentioned that because I'm relatively new to the South, different population. At the VA, I see, I would say, a majority of African-American men, and that has a real impact on my professional experience compared to what I did in New England. So, but it's really a privilege to serve veterans. Maybe some of you are veterans, but I really enjoy the work. I find it very gratifying. And there are only a handful of things I miss about private practice. So anyway, I'm blabbering a little.
Yeah, I didn't know there was a Harlem in Holland.
Well, where do you think Harlem came from?
Oh, excuse me.
And New Amsterdam and Brooklyn, they're all little towns. Well, Amsterdam's not a little town, but yeah, so New York City was originally New Amsterdam.
Oh, okay.
So there we go. and it's Haarlem. I speak Dutch. So again, personally speaking, you know, my family, we have heart disease, but we don't have prostate cancer. I kind of quiet and introverted. I don't have a lot of friends. And so I really don't have a personal relationship with prostate cancer. So I think I'm generally pretty sensitive in terms of bedside manner, but at the same time, I'm really kind of clinical here, so forgive me. I have a whole bunch of slides on the anatomy. So I try not to belabor it. So we have the urinary tract. As urologists, we do everything from the adrenal glands here, the kidneys, the ureters, which drain the urine, to the urinary bladder. And so here we have the urinary bladder. There are these little dimples. These are where the ureters, these tubes that drain from the kidney, drain into the urinary bladder. Kidney stones, they tend to get stuck right at that area. So the prostate sits below the urinary bladder. The urine passes through the bladder and out through the urethra. So this is a cross section. I thought it was kind of helpful because men, unlike women, I may go long. Somebody should probably interrupt. Dr. Holness, please interrupt me.
Doc, are you sharing your screen with us? Are you sharing your screen with us, please?
Yeah, we're asking about permission. We didn't tell that. Someone ask you.
Remember to share your screen with us, please.
Yes.
Well, Marcel, I think we're seeing.
Yeah, I see the screen. Marcel, are you not seeing the screen?
No, I'm not.
Just you're on your phone, then swipe to your left
Okay, no
or right.
problem.
But we are.
All right. Okay. Okay. Good. I'm sorry. Okay.
So just real quick about the prostate. A lot of what we deal with in urology is prostate enlargement, urinary symptoms. So as we get prostate enlargement, the urine gets a little more resistance to the flow of urine. Below the prostate, we have something called the external sphincter. And so in men, we have an internal sphincter, which is where the prostate and bladder meet. That's relevant because when we operate on the prostate, this internal sphincter is gone, and we rely exclusively on the external sphincter, which is the only sphincter in the female. And I'll get back to the anatomy just a little bit more. You know, I understand we're all adult men, and you know, I'm very used to talking about sex and anatomy. So cover your ears if you're not ready for that.
Oh,
Sorry, very
Don't worry.
sarcastic.
They're ready.
All right. So the reproductive organs, I don't know how relevant it is, but in terms of the anatomy, we have the ureters. So again, they drain from the kidney. Urinary bladder here is storing urine. So the semen comes from basically three sources. A very small amount of semen is actually comprised of the sperm, so produced in the testicle. The vas deferens, vasectomy, is the conduit for the sperm into the ejaculatory duct. So the majority of seminal fluid or semen comes from the seminal vesicles, and then a small percentage, 20%, are secretions from the prostate. When we have an orgasm, the semen comes out through the urethra. I kind of think it's relevant to say, oh, and then I'll just go on a quick tangent. Prostate enlargement, one of the medicines we use for prostate enlargement it's called Flomax or tamsulosin. Side effects, one of them is a less satisfying orgasm because it inhibits the bulbospongiosus muscle. We see that with other things too. So it's kind of a medical student lecture, forgive me. So prostate cancer is really what I'm supposed to be talking about. Quite common, but I think it's really, really important. And I really emphasize this with each patient I see, that although prostate cancer is extremely common, it's very slow, and the majority of men will never have problems from it. So, you know, the leading cause of death is heart disease. And, you know, I think it's just really important that we look at the big picture. Sure, I'm a urologist, and prostate cancer is why people come to me. But in terms of overall health, there are many things we can do to stay healthy. So we have some risk factors that are out of our control. African Americans are a significantly higher risk for prostate cancer than non-African Americans. Family history of both prostate and breast cancer. You may not have prostate cancer in the family, but if your mother, her sister, and your sister all have had breast cancer at an early age, well, you're clearly at risk for prostate cancer. Immunocompromised, so HIV, maybe immunosuppressed people. You know, our body defends against cancer with a lymphatic system. Cancer cells express abnormal proteins. The immune system will identify these early cancer cells. So when we have a compromised immune system, it puts us at a significantly higher risk for prostate cancer.
Dr. Lalamat, a quick question. The African American risk factor, is that more genetic? Is that more because of lack of access to health care or socioeconomic issues? What kind of, can you tease that out, or is it known?
It's clearly genetic, and access to healthcare is a major issue. I don't think we have a good understanding why African Americans have a higher risk for high-grade disease, and I think it's really has really influenced my recommendations, which are always individualized. But and this is a part where I want to draw people in before I start ranting a little bit in terms of what I think the best things to do. But I would say socioeconomics are really significant, but we don't know for sure what it is about being African American that puts you at higher risk. The Mediterranean diet, so Southern Europeans are not at as high risk. Hispanics are somewhat high risk, whereas East Asians aren't. And then Northern Europeans, so Polish, Scandinavian, German, Dutch, they're at a higher risk too. But African American being a significantly higher risk. And again, I mean, early detection is really critical because when you only go to a doctor now and then, let's say your colonoscopies every 5 or 10 years, well, if you're not doing routine checkups, you know, a lot can happen in a couple of years' time. But again, prostate cancer being very slow and often not a cause of death or even suffering, we don't want to overdo it. So I have, unfortunately, I would say a professional bias here in terms of prostate cancer prevention. Generally, there isn't a lot we can do. I mentioned the immune system, so the top 3 things, and again, the slide is very small, so I apologize. Low-fat, high-fiber diet. When we're eating an unhealthy diet, high in sodium in this country, but also high in fatty foods, more animal protein, or particularly beef and pork, that's going to increase our risk for cancer, colon cancer, and also to a certain extent prostate cancer. So leafy green vegetables, a variety of different vegetables and fruits are going to be really important. There was a study I came across that showed that men who changed their lifestyle to become vegetarian after diagnosis, it didn't affect their course. That is, some people are going to wind up with a more aggressive prostate cancer, whereas some will be cured. Number 2 here, in terms of prevention, it is not popular. It's not something that I advocate, but there are 2 prescription medications which we use for prostate enlargement. We tend to use them. We tend to use finasteride and dutasteride when the prostate's enlarged and Flomax alone isn't doing enough to help with urination. But these 2 medications work on the metabolism of testosterone. And although you still have testosterone, the lack of DHT causes the prostate to shrink. It's also been shown to decrease the risk for prostate cancer. There really shouldn't be controversy about this. There is, however, because when this data first came out, it was said, well, it decreases the risk for prostate cancer, but it actually makes it more aggressive too. And that isn't the case. Under the microscope, it can look deceptively more aggressive, but it doesn't behave more aggressively. So finasteride is not an appropriate choice to prevent prostate cancer, in my opinion. And the side effects being decreased sexual desire, erection trouble, and not altogether uncommonly, I think it's more than 3%. We'll see breast enlargement, a male breast enlargement. There was a study that looked at selenium and vitamin E quite a while ago. It was called the SELECT study. There was no evidence that those two, vitamin and mineral, could prevent prostate cancer. There are a lot of people who will promote the following. So saw palmetto, beta-cytosterol, pygeum, ryegrass pollen, lycopene, zinc, or green tea. Whether it's super beta prostate or any variety of things you can buy. Faith is important. People get peace of mind from making a lifestyle change or taking a supplement or maybe drinking a certain type of water. If that's going to give somebody a great deal of peace of mind, I don't have any reason to believe that any of these supplements would be harmful. But you have to realize that whenever you're buying a supplement, it's not regulated by the FDA. They can sell you anything they want. They may say, oh, it's pure saw palmetto, but it could be anything really. So I've heard my wife say more than once, people are always out there trying to separate you from your money.
Oh,
so
okay.
Supplements at your own risk, I should say.
Hey, Doc, just a comment on the exercise. I've always heard about the low fat, so I'm glad you brought that up, but the exercise, how does that contribute to prevention with respect to prostate?
Well, I didn't list sleep hygiene, and I think I don't think technology has helped us develop better sleep habits, quite the opposite. But I think sleep and exercise are really important to maintain one's immune system. So the immune system is the body's mechanism to attack cancer cells before they have a chance to outsmart the immune system and start to grow and potentially spread. That's the purpose of our natural killer cells and some of the white blood cells in our immune system. They're designed to recognize cancer cells which are expressing an abnormal protein.
Wow.
Thank you for that question.
Unfortunately, we're in a country where we probably sleep the least among other countries. So.
South Korea is thinking about changing their work week from 52 hours to 69 hours. Wow. That was in today's New York Post, the Washington Post, I think. So again, probably more anatomy than you care to see, but this image on the left is very similar to what I showed earlier. We have the urinary bladder. The urine passes through the prostate. So within the prostate, we have all the secretions. Actually, that was just, I don't know, the secretions within the semen. All those secretions that are produced come out through one urethra, okay? So in the prostate, we have all these little tiny twigs or branches, if you will, that produce a variety of proteins and secretions, an alkaline solution, a variety of things. The seminal vesicles will produce fructose. Anyway, there's these little tiny microscopic tubules that feed into larger openings, let's call them branches, and then larger branches, and then akin to a tree, we've got one urethra. So this is a drawing I really like. It's from a medical student, from what I understand. I show this to my patients routinely. And now the lack of magnification really hurts us here. But these cells that are lining the ductwork, if you will, of the microscopic glands within the prostate, these cells are lined up like kernels on an ear of corn. They're nice and tidy. The nuclei are uniform, and it's within these ductwork that the cells, the individual prostate cells, are secreting a variety of things, including PSA. So that's a big part of prostate cancer, PSA. What's my PSA? Well, specifically, PSA is prostate-specific antigen, but it actually serves a physiologic purpose. So it's a protein that's produced in the prostate, which is secreted into the seminal fluid. The PSA's purpose is to dissolve the mucus of the cervix so that the sperm can enter the female uterus. So I talked a little bit about prevention. I'm fairly cynical about supplements. So healthy lifestyle, and we have no control over our genetics. And again, it's important that I'm empathetic to those who have a strong family history, and I think professionally or on an individual basis I am, but I fear that in the course of this talk I may came off as opinionated. But let's move on. So early detection, we do want to do annual prostate exams starting at age 40. I don't know if it's because I deal with veterans or Southerners or what, but in New England, people didn't complain about their prostate exam. Some did, but it was pretty routine. And guys are really jumpy here. I didn't go into urology because I love doing prostate exams, but you got to suck it up. I mean, that's just what we do.
Suck it up. What are you talking about, Doc?
A prostate exam.
That's my private parts. What are you talking about? You guys in Massachusetts, I don't understand that, but here in the South, we're a little sensitive.
All right. So we use lubricant. Yeah, funny guy. We use lubricant, and I'm a tall guy, but I have a very slender finger. An awful lot of urologists have short, stubby fingers, and they're not actually going to feel the prostate. Use a lubricant. My finger's smaller than the average stool, so just takes a moment. I'm gentle. Anyway, so the PSA test is controversial. In 2000, I want to say 2008, up until just 5 years ago, the United States Preventive Medicine Task Force and the American College of Physicians was opposed to the PSA blood test, whereas American Cancer Society, National Comprehensive Cancer Network, and the American Urological are very much in favor of the PSA. But we really want to be careful who we order the PSA on, this routine blood test, because of the, we don't want to over-test because it'll create a great deal of anxiety and perhaps unnecessary procedures. Again, prostate cancer being so slow, if we made a diagnosis of an early prostate cancer, we may not have helped the patient in terms of their quality of life or longevity. So African Americans being at a higher rate, we do recommend PSA blood tests starting with the rectal exam starting at age 40 up until the age of 70. Also for non-African American men who have a family history of prostate cancer. Otherwise, the Caucasians, Hispanics, Asians, we would say age 55 to 70. Now, this is important, and I feel like these next three things actually on my slide, I think are really quite important. The three bodies here, American Cancer Society, National Comprehensive Cancer Network, American Urological, we don't want the PSA blood test done in men who have less than a 10-year life expectancy or those who are more than 70 years old. And that sounds ageist. That sounds really unfair. But it's back to the fact that prostate cancer is very, very slow. So no provider should look at a patient and say, oh, I can say confidently, you don't have 10 years to live. I think you have to be pretty bold to make that judgment. But honestly, I'll see guys where I just don't think it's appropriate. Oh, I was just going to say something. Oh, well. So number 2, with the PSA blood test, there's something called the age-adjusted criteria, and the laboratory normals will say, well, the PSA should be between 0 and 4.0. Well, in the younger guy, the PSA should really be lower than that. And the lab won't reflect that. So I think it's reasonable to know exactly what the PSA is, as opposed to, well, it's normal. And another really important issue is PSA velocity, and it's sort of a silly term, but it representing or specifically referring to the increase of the PSA. So if the PSA is consistently around 1, and then it goes up to 2, and then the following year, 2.8 or something like that, you still have a PSA that's less than 4, but you really have a significant increase in the PSA. I think this is a good time to state clearly that PSA is not a test that diagnoses prostate cancer. It's a screening test. So the abnormal PSA could mean that there's prostate enlargement. And when we see a PSA that's normal and then gradually increases and maybe gets above normal, that's still probably prostate enlargement. I think I've been speaking kind of quickly and I have more to cover, but maybe
Doctor, I got a question. And some of the guys, we've got a large group here. We've almost have 30 guys or 30 people on the line. So we have a large audience. So I want people to feel free to put questions in the chat. Roland, I haven't checked the chat. So if you can check the chat and see if there are any questions. I haven't checked it out yet. But feel free to ask your questions or to unmute if you have a question with some of the slides. Dr. Abel Alamant has gone through some of the anatomy, and now he's going through some of the diagnostic tests that we use. One question I would throw out to Doc is, why would if there's a test out there like PSA, or a blood test for me to check and to screen, why would I need a rectal exam?
I have seen a handful of cases where we have a very aggressive prostate cancer that has a normal or near normal PSA. And more importantly, we don't want to do a PSA on the 7-year-old male because we don't want to see a PSA of 4.1 and get all excited and do a biopsy on something that's not going to affect that man's longevity or quality of life. I've seen, just like I think it's very normal to do a prostate exam, I think a lot of providers don't. My personal doctor does, and he's a small, skinny guy. He's Dr. Holness's size, and he's so rough. I have no idea what he's up to when he does his exam. And I've told him more than once. In any event,
using lubricant.
No, so sure. I'll see a guy who hasn't had a blood test, and all of a sudden his PSA isn't 4, it's not 10 or 20, but it's well over 100. I've seen 4,000. I've seen a PSA of 4,500. PSA over 20 is not good. A man whose PSA is, approaching 100, that's not a curable situation. But if we can find a prostate nodule and then go back and say, I wonder if that is a PSA, it hadn't been checked in a while, that annual prostate exam is really very important. So, there'll be pushback from providers and from patients, but that's the party line.
And the other question I have is that you talk about the high risk for African Americans genetically and socioeconomically and that sort of thing. So would it be wise for an African American, because we're in a higher risk, to make sure we do get a PSA?
Yes, I think all men should be screened annually with a PSA. But point two here is controversial. The PSA is controversial. That is, I'm going to repeat your question in just a moment because I've already gone off on a tangent. We don't want to do a PSA. Sometimes it's inappropriate to do the blood test because it's going to lead to a biopsy. It's going to lead to additional testing, which is going to cause worry, potentially risk, and compromise the quality of life. But Ken, your specific question was African Americans. Yes, African American men between the ages of 40 and 70 should have a once-a-year rectal exam and a PSA blood test. And I think it's reasonable to ask, what was my PSA? What was it last year? And it can drive us crazy. And, as a urologist, this is my bag. But as a doctor, I got to tell you, I'm more interested in, hey, what's your systolic blood pressure? What's your A1C? What's your cholesterol? Because ultimately, those are really critical to a man's health. And the PSA is up there too.
I do have a question on the chat. It says, it's talking about enlarged prostate, BPH. What should a man with an enlarged prostate do? This is from one of the on the chat.
So we'll see guys who are told they have an enlarged prostate and they don't have symptoms, and that's fine. With prostate enlargement, we commonly see somewhat elevated PSA. If the PSA is elevated, you should be seen by a urologist. On the other hand, if the prostate, when examined, is smooth and the PSA is normal, then you really don't have anything to worry about. Prostate enlargement is sometimes a term that's used when a guy will have urinary symptoms, a slow stream, peeing too often, waking up at night, strong urges. Maybe once you finish emptying, you think you're empty, you stand there, you shake a little bit, and wouldn't you know it, a little bit gets on your clothes anyway. We have medications, Flomax being a very popular one. I mentioned it probably a half hour ago. Flomax can compromise a man's orgasm and cause retrograde ejaculation, but a variety of medicines that can help. Would saw palmetto help that guy, or super beta prostate, or whatever the newest latest thing is? Well, the data says no. We used to recommend saw palmetto. There are urologists who will sell it out of their office. That doesn't make it right. So, the prescription medicines work, and saw palmetto is not any better than placebo, and that's been, studied in placebo-controlled studies. So that's it looks like there's quite a few questions on the chat.
Oh, okay. Hold on a second. Let me see. Okay. Dr.
Can I ask
Karen.
a question?
Yeah, go ahead. Go ahead. Ask your question.
Okay.
Introduce yourself and then go ahead and ask your question.
Okay, I'm Dr. Len McCallum. I'm an optometrist, but I did a presentation recently and I was looking up some information on the prostate, and I noticed that the Africans have a lower risk, a lower percentage of them getting prostate cancer than African Americans and Caribbean people. Why is that so? Do you think it's strictly genetics, or do you think it's diet, a change in diet that we have in our Western world that's the cause?
Well, I think the latter. Would you likely agree? Or
Yeah.
you're, yeah. Yeah, I think the high fat, low fiber diet, saturated fats, you know, processed foods. I mean, we don't really know what we're eating, do we? And drinking.
No, exactly. Thank you.
I wish I could tell you definitively, but it is, you know, being a vegetarian, it's a hard sell. But, you know, my patients with kidney disease, kidney stones, you know, there's a lot to be said for limiting your animal protein intake. That's my rule of thumb. And low cholesterol meats. So if somebody can, Dr. Holness, if you want to keep reading through the chat box.
What do you want to do? You want to continue? Because Dr. Carrington had one more question. Maybe we can do one more question, then we can go on to your lecture. I'm trying to scroll up and I'm having a hard time. Dr. Carrington, why don't you ask your question? There's something about high risk.
Yeah, my question was, should high-risk African-American males be screened earlier? Those folk that have like a family history of prostate cancer, et cetera.
Yeah, I was looking at that this morning. The answer is no, not till age 40.
Okay, thanks. Because I had a friend who actually got his prostate cancer before age 40. That was just happened by accident, but I know that the epidemiology may not always support screening before 40, but I was just wondering if there's any other later data on that.
You know, I think the term epidemiology, it's a bit of a heartless field, isn't it? We're no longer doing routine urinalyses. That was something I thought should be done, and that's no longer recommended by the internal medicine docs. You know, cost effectiveness, I wouldn't say healthcare rationing, but your risks and benefits. So when we find aggressive disease, we need to treat it aggressively. If somebody has prostate cancer under the age of 40, it's really not a good prognosis. Could you have caught that man earlier? I really feel insensitive to anyone listening, but I don't wish to be insensitive, but you know, there's some cases where somebody's going to be metastatic and uncurable before we find it, no matter what testing we do.
So yeah, just piggybacking on Dr. Carrington's question, we talk about high risk with Black men with prostate cancer. And you're talking about aggressive testing. So when you talk about aggressive, you had mentioned at the beginning of your lecture about the aggressiveness of prostate cancer in Black men.
Yes.
So does that tie in with being more aggressive? And I think you answered my question. Does that tie in being more aggressive in the testing with a certain population, such as Black men? Does that tie in? And I think you're leaning towards no, just you don't do all this screening before 40, but we are at higher risk. So testing is going to be a little different. Is the aggressiveness in screening going to be a little different? What do we do to prepare for that?
Right. So I think diagnosing anybody with prostate cancer before the age of 40 is exceedingly rare. And people who are not at risk for prostate cancer really shouldn't be screened until age 55. And that's, you know, I always thought it was 50, but it's actually 55. Having recently reviewed this also for the board exam not so long ago. So that's going to catch most of them if we're doing it diligently. And again, epidemiology, you know, we don't want to spend so much money on healthcare that we're doing, you know, expensive testing when we don't need it. So fortunately, for those of us who have a PSA that's less than 1, we actually don't need an annual PSA. Because it's unlikely And I really, this is pretty clear. It's unlikely that you're going to develop prostate cancer in the near future if your PSA is, let's say, 0.5 or so.
Okay.
But so the age-adjusted criteria, I really think that's important, and I think that's a fair question for those who are getting screened. Well, what is my PSA and what was it last year? Because if it's 4 but you're only 45, or sorry, if it's 3 and you're only 45, that's not exactly right. That's not. We don't really want to. That needs to be seen by a urologist at that point. If you're around 2.5 and you're in your early 50s or younger.
Yeah,
All
I do agree with you that the intensive screening before 40 is really not necessary. But I just want to know if there's any other later data on that. Thanks for your review and backing up that point of view. But if you meet a patient who obviously has a family history of prostate cancer before age 40, then I think that you owe it to that patient to be a little bit more aggressive in your own thinking. Not necessarily that we do population testing on everybody before 40. Thank you very much.
Yeah, I have no problem. I think that's a good follow-up. I have no problem with that. This is something I didn't think of until just now, but blood in the semen is a pretty freaky thing. And it's generally not associated with prostate cancer. So, we commonly are asked to see people for blood in the semen. As a rule, I'll do a PSA and I'll do a rectal exam and then a urine sample, make sure there's no urinary infection. But blood in the semen doesn't seem to be associated with prostate cancer, which is, reassuring for those who do experience that. But it does warrant, at least a doctor's visit, if not a urology appointment.
Hey, Doc, let's go ahead with your lecture. There are a couple of questions. There's a question from Paul and another question from Patrick, but let's hold off, you guys, and then I promise we'll get back with you. We'll let him go ahead with a few more slides, and then we can ask some more questions from Dr. Avlamont.
We're only about halfway through the slides, and honestly, I prefer the talk that we're having now as opposed to my last couple slides when we talk about prostate cancer treatment, because that's where I'm really concerned that I don't want to offend people because of my professional bias. So, but I appreciate the questions. So we can skip right through this.
And we forgot to mention the disclosure, I guess, so just to tell everyone that this is more educational. And I asked Dr. Avlamont to come on and give a presentation, but it's very important that if you're having any issues, any medical issues, prostate issues, urinary issues, that you talk to your local primary care physician, urologist, specialist in your area. But this is more informational for our group.
So we won't keep this slide on the screen too long. Anyway, so patient says, well, I just had a colonoscopy. I don't need a rectal exam. When we're feeling for the prostate, we're feeling for a hard lump. Here's my hand. So the thenar, the soft tissue here between the thumb and the knuckles, this is what a prostate should feel like, as opposed to a hard nodule. When you're doing a colonoscopy, the prostate's a speed bump. You got an enlarged prostate, the scope is just going to pass over it, but it's the tactile nature. So using a lubricant, my finger's not that big. Yeah, sure, it's one way only. I hear this all the time. Let's just get it done and over with. It's only a few seconds. A moment ago, we talked about prostate enlargement. It's a big part of what we do in urology. We have a medicine that shrinks the prostate, but more importantly, we have Flomax, alfuzacin, medicines that will relax the bladder opening and allow the flow of urine. This fellow enlarged prostate, this is not prostate cancer. It's why do people get prostate enlargement? Well, it's variable. Prostate enlargement is not the same as prostate cancer. One doesn't necessarily lead to the other. The enlarged prostate, could be hiding a small amount of prostate cancer, but they're often quite distinct. So I put this up here because what is the doctor actually, what is the provider feeling when they do a rectal exam? Well, I showed you with my hand. Is it something soft and fleshy or something hard? Okay, so this is what other tests are out there? So we talked about PSA, and we're going to say age 40 or less, 2.5, and age 50, roughly, it should be 2.5, or 0 to 4 for men that are over, let's say, into their 50s. Now, if your PSA is between 4 and 10, again, that being abnormal, the laboratory will often automatically provide a separate number, and that's called the percent free PSA. And it's an inverted relationship. If your PSA is over 4 and your percent free PSA is on the higher side, then that's okay. So let's say a guy comes in, he's got a very large prostate. It's not the size of a walnut, but it's the size of a lime or even bigger. The PSA is 4.5, but his percent free PSA is 35% or so. I'm not too worried about him. And if he's actually 70 and not in perfect health, I'm not going to recommend any more testing probably. I'd rather just keep an eye on him. Everybody's an individual, but we don't want to be overly aggressive when we have some reassuring factors on the blood work. I don't usually hang my hat on a test like the percent free PSA, which is to say, if that test is normal, I'm not going to say, oh, you don't need to worry about it. I tend to want to be on the more I don't want to use the word aggressive, but let's say thorough. I don't want to miss a prostate cancer on the off chance that it's actually one of the aggressive ones. Sure, there are plenty of prostate cancers that are not aggressive that we really shouldn't even be treating. We should just watch them. But that's the real controversy with this disease. So a separate blood test, which is not widely available, it's proprietary. So a lot of the insurance companies won't pay for it. We can't get it in our institution. It's called the 4K score. It has one additional thing in addition to the PSA. It would have the human kallikrein related peptase 2, and they give you a score, and they give you the standard range. And if it's abnormal, then that may increase the risk of suspicion in terms of should we be doing more. The 4K score is not something a primary care provider is going to get so much. That's really a urologist may do that. So there's a concept called prostate massage. You don't want one. A prostate massage is a very uncomfortable prostate exam. And after a prostate massage, a urine sample can be collected and sent to the lab for one of these tests. And that can also increase or decrease our suspicion for prostate cancer. The urine tests that are available to screen for prostate cancer are not mainstream. They're certainly out there, but again, I don't want to look for excuses not to find prostate cancer. I don't want to tell guys, oh, this other test is normal, we have nothing to worry about. I gotta be on the more compulsive side of things. Okay, so the meat of the discussion. So the PSA is elevated. The PSA is abnormal. So now what? Well, an awful lot of providers will say, oh, there may just be an infection. I'll give you a month of antibiotics and see if the number comes down. I'm not into that. We're doing a test to look for prostate cancer. If this is a guy with urinary symptoms, if there's an abnormal urinalysis, let's diagnose a urinary tract infection before we even do the PSA. But I don't want to treat an abnormal test. The test is a screening tool. So you have an abnormal PSA, well, you need a urologist, and the urologist is probably going to recommend a biopsy. Again, we have, as urologists, we have some expertise. We may say, I'd rather just watch it, considering your other medical problems. But back to what I've said at least twice before, Take a deep breath. Prostate cancer is slow. The PSA doesn't diagnose prostate cancer. It's a screening test. We're going to have prostate biopsies that are negative, and we can't, and that's because the PSA is not diagnostic. So some of the prostate biopsies are going to show cancer and others won't. Statistically, about 1 in 3 of the biopsies are going to show cancer. In my practice, it's always been a little higher than that, which is to say that maybe I should be even more cautious about, maybe I should be doing even more biopsies just to make sure I'm not missing them if I'm finding more than 1 out of 3. Prostate cancer, very slow growing and not a common form of death, a cause of death. So rather than stop for any questions, this is kind of repetitive. The prostate exam with the finger, do you feel a hard lump like a knuckle here, or is it soft and fleshy? This says BPH, benign enlargement. This is a model. They actually have these little this 3-dimensional model that has these little rubber prostates mounted on a piece of plastic, and sort of for students or young doctors, providers, to check, is there a nodule? This one has a little lump here. Is it simply asymmetric, where the left side is small and the right side is much bigger? Or is there a big hard tumor here? This is a close-up of a slide I showed before. The cells on the normal prostate, this is a drawing now, the cells are lined up nice and tidy, like kernels on an ear of corn. And now we have cancer cells, where instead of a thin row of prostate cells, adenocytes, we have these crowded cells with really prominent nuclei. So under the microscope, this is cancer, and then this is not. Ken, were you waving to get my attention?
No, I was waving at my daughter.
All right,
So
maybe
you look at
you want to open up the chat box again?
Yeah, when you look at the slides, it's interesting. So one is more uniform, and the other one is, you see disarray with the, you know, in the malignant side. So
it's very technical, and then they do staining to see. You know, this doesn't involve immunohistochemical staining, but they do additional stains when there are questionable areas to be 100% sure, is this really cancer?
Okay.
Let's see what's in the chat box.
All right. I'm waiting for more questions, but there are a couple of people that we're gonna go with their questions. So Paul Clark mentioned taking Flomax for many years, and he's had some bad urinary experiences. And he was wondering, is there something with less side effects?
I prescribe an awful lot of alfuzacin, which is also called uroxetrol. Flomax is usually taken at nighttime, bedtime, and alfuzacin with food. Very similar medicines, but the alfuzacin, I guess we can look at this one. Well, no, I want to go higher. The alfuzacin, doesn't, it will relax the bladder neck, but not impair the bulbospongiosus muscle. So with alfuzacin, you're not going to have retrograde ejaculation or a less satisfying or powerful orgasm. And you're also somewhat less likely to have the dizziness or lightheadedness that we see with Flomax or tamsulosin. So I really do like alfuzacin. It's not as widely known, but it's very good medicine. The other one, Rapaflo, is newer, might work better than Flomax, might have less dizziness or lightheadedness. All 3 of those medicines can cause sinus congestion. And then there's some other alpha blockers that are really designed to treat blood pressure, but they can also be sometimes more effective or better tolerated than the Flomax. If Flomax hasn't worked, then maybe a scope procedure, maybe an ultrasound, maybe that medicine I had early on called finasteride, which shrinks the prostate at the risk of some adverse side effects.
Doc, may I ask another question?
Yes, please.
I know Flomax affects those who are having cataract surgery because it causes the iris to become floppy. Do the other drugs do the same thing?
Yeah, so you're an optometrist, right?
That's correct.
Yeah. So side note, there have been a couple of cases, very few reports of Viagra causing blindness. Viagra and Levitra can cause temporary blurry or bluish vision.
Yeah.
Cialis doesn't. So, but the Flomax, floppy iris syndrome, Flomax is given for kidney stones too, incidentally. It helps people pass stones, men and women. It's probably a little overused by the ER docs because most people will pass a stone without needing that. But if you've ever been given Flomax and you need cataract surgery, it's something that the ophthalmologist probably wants to know. And as I understand it, the ophthalmologist, because the iris is floppy during the cataract surgery, it just takes a little more precision, I guess. But they're familiar with it. They know how to deal with it. The Flomax itself doesn't cause cataracts. I don't think that alfuzacin. I'm afraid I don't know, but I don't think alfuzacin should be considered safer in terms of, well, one day I may need cataracts. And I don't think, I wish an ophthalmologist would comment on this, but I don't think an ophthalmologist would say, oh, I wish you never took Flomax. I hate that medicine. I don't think it's that big of a deal.
Well, they have to be aware because if it flops into when they're sucking out the lens, they can actually rip the iris and damage it. That's what happens. It flops instead of staying stiff. It collapses into the field where they're working, and that's what happens.
So if the ophthalmologist knows this ahead of time, then they anchor the iris. They secure it so that it's less likely to move around.
Yes.
Right.
Yeah, they're more careful because they're using ultrasound to and a vacuum to suck out the cataract. So they want to make sure they don't get that suction anywhere near the iris, or it's going to move and go right into the suction tube.
Yeah. Yeah. I never. I'm glad you mentioned that. It's interesting to hear it from your point of view.
Yeah, but I wasn't aware whether the others, I've never heard that with the others. That's the reason I was asking, because I'd never heard it with any of the others, but I didn't know for sure. So
I'd be surprised if the others don't do that to a certain extent. Again, if it's Flomax is up there in terms of the list of commonly prescribed you got Synthroid, you got Lipitor. Flomax is high in that list. And I don't think the ophthalmologists necessarily stamp their feet when they see it on a medication list.
Yeah, but they always want to know. That's one of the things they specifically ask about.
Yeah, and so some of the female patients who had a kidney stone may have gotten it without even realizing it.
Ah, okay. Well, thanks again. Thank you.
That's a great question.
There was another question, Doc, that somebody mentioned here. I think it's Patrick. And he had mentioned, what is the Black study based on? And I'm blanking out on what Black study is referring to. You might remember. And what is to educate the Black population? Do you remember what study he's talking about?
Well, I didn't cite any studies, but African Americans being at higher risk, it's just, data that's been accumulated over decades. We're just seeing African Americans clearly have been presenting with higher risk, more advanced disease, with a higher incidence of disease. So the earlier slide, I don't have a breakdown, but if 1 in 8 men get prostate cancer, American men, well, I don't know. Does that mean it's 1 in 6 African Americans? I'm afraid to say I didn't look at that breakdown specifically, but
Is
there
this
is.
study was done in America or a worldwide study?
Maybe I can
United
answer that
States.
because I just did research on it. It's about 2.5 times higher in African American men than in the other group, as Europeans especially. It's also, there have been many studies that have confirmed that it's higher. In the United States, it's like that. It's also in England, the Caribbean, throughout the Caribbean. So one of the highest places is Martinique, and most people don't know that. It's high in Trinidad. It's high in many countries our people come from. So that's why I was asking about the food earlier.
So what can we do to just keep on saying the same thing and doing to help the black man, the black population? We're gonna die out.
Get screened once a year.
We gotta wait till we're 40. I've known my family member who have it less than 40, who have prostate cancer less than 42 of my family member.
So that's the reason why also Dr. Avila had mentioned looking at it individually. So, working with your provider, and if they feel like you're at higher risk, working and doing it that way. But, that's why you look at these, when you're doing these researches, you're looking at general populations, but then, do you have research specifically looking at, you're talking about globally, but I think some of the research they've talked about with the higher risk here in America, we kind of rank high in across the world. So, and those are for different reasons too. So, but yeah, that's what makes it kind of difficult when you're looking at different populations, especially our African American population. And I don't know, I'm going to throw this out with Dr. Avlamat. Just even look at America. You look at the South, you look at the Northeast, you look at West, and we know in the South, we have higher risk of, it seems like higher risk of diabetes and high blood pressure and cancer. And that has to do with, that some of that is genetics with respect to what demographic group you're in, but that also that has a lot to do with something socioeconomic issues that we deal with too. So, somebody mentioned, go ahead.
I have a comment.
Okay, who's speaking? Somebody, I think.
Go ahead,
Goodman,
bro.
Goodman has his hand up.
Yeah, put your hand up. I'm in my car. Wait a minute, let me say one thing. Before I go, I'm in my car, gonna go back to church. But what I want to say is that you looking at everything else, but you're not looking at the DNA. It's calling on what my ancestors ate and did stuff, our bodies break down easier because we want to get in the proper diet.
I think that's fair.
Okay, so you heard that, Doc? That's Ken Farley. That's Ken, right? Is that Kenny?
Yeah, right. That's me. Yeah,
All right. So you mentioned DNA, and you're looking back, ancestors, and you're talking about genetics and the higher risk that we would have.
Right.
Okay. All right.
Mm-hmm.
Okay.
Yeah, I agree.
I think Goodman has his hand up. You want to go ahead and unmute your laptop or phone?
Yes, my wife does. My wife and I do lots. Well, first of all, thank you for what you have been sharing, Doc, about prostate cancer. The message just needs to get out. Take care of yourself. Get tested on a regular basis, and that way you'll be ahead of the game. My wife and I do lots of lectures, and there's one study that she did that she cites, and I don't have the study right before me, but she cites that that there is such a higher incidence of
prostate cancer in African American men. And as they did this study, they found out when they went back and they crunched the numbers, they found out that the Black men had a inordinate amount of chicken wings that they ate on a regular basis. That was the one thing that stood out in this study, that a lot of Black men were eating a lot more chicken wings. And I wonder, when you mentioned about other predominantly Black countries or places where higher population of Black, whether there was a higher incidence of eating meat. And you mentioned, the doc, that you would recommend cutting out that red meat, the pork. Those things are very high on the level. And the research I've done, when I do my presentations, the research I have done has found that cheese, which is high cholesterol, saturated fat, high consumption of that is also a precursor to folks getting higher incidences of prostate cancer.
The chicken wing comment is really very pointed. I have to say, it makes me uncomfortable to hear that. It's a high-fat diet is clearly unhealthy. I think the American diet predisposes us to high blood pressure, cholesterol, and diabetes, which will lead to stroke and heart attack, and premature disability. I mean, that's really quality of life, longevity, losing our independence. But to narrow any illness to a single food, I think there are too many variables in life to really say, well, it's one thing in particular. Chicken wings are popular. They're not healthy. It's not red meat, right? But it's fried food. It's chicken skin. It's not healthy.
I agree with you. I agree with you 100%. I like to steer away from telling people that it's one specific, just like it's very hard to say one specific thing is a causative factor. I run into the fact of people coming in saying, I heard that this one thing is really good for. So on both sides, I have people in my clinic where they will tell me, well, you've got to have pomegranates, or you've got to have carrots. I steer people away from that, because it's not just one thing. It is a lifestyle that predisposes you to. And if a person is not physically active, they aren't taking care of their body, they're not getting their rest, they're not drinking a good amount of water. There's a lot of things, a lot of variables, just as you said. It just so happened that in this study, that's what they found. And I would lean it towards, they probably were heavy in your meats, in your dairy, along with that, but coincidentally, they happen to eat lots of chicken wings.
I just have two comments. One is silly. I was born in Holland. The Dutch eat more cheese than anybody. I didn't realize that puts me at risk for cancer. but that's why the Dutch are tall. Well, I mean, Anyway, but I agree with you completely about whether it's beet juice or pomegranate. And I'd like to go back to something I had on one of the slides, and that is peace of mind, or really, and I don't want to be too rosy or cute, but community and spiritual well-being. So when one is at peace, when one has support, when one has loved ones, when you're part of a community, you have a better quality of life. You have a better, any number of things can be better. So yes, exercise and diet, but we treat people, we're all individuals, and our wellness doesn't come from one nutritional supplement. We're complicated beings, but being part of a community, and I mean, I think that's what you have here is a really special thing, and I admire it.
Yeah, we had spoken about on previous discussions like this, how loneliness is a risk factor, increasing risk for depression, especially during the pandemic. We've noticed that with mental health. And so we also know the importance of mental health and how that affects our physiology and affects a lot of the different disorders that we might have or aggravated. So we really appreciate making that comment about how important it is to having social support, family support, friend support. And we've been on this line for the past 3 years now, going on since 2020. And we've gotten together weekly and going through these discussions. So we really appreciate you presenting. We're going to go, I told Doc that we weren't going to keep him too long. We're going to go till 4, and I think we got 10 more minutes. So Doc Ablamond, if you want to.
All right, I'll scurry through. It gets a little more controversial.
Okay. Well, we're not into controversy, so so you can slide through them.
Well, controversial. That's where I become opinionated. Okay, so let's say you've seen the urologist. You had a prostate biopsy. There's 3 different numbers here. We have stage of cancer, the grade or the score, and then the PSA blood test. So we talked about the PSA. Ideally, it's going to be under 2.5 or under 4. The spaces didn't work out right. There should be a separation here. So if your PSA is between 2.5 and 10, you're in the lower risk category for prostate cancer. If your PSA is between 10 and 20, that's an intermediate risk prostate cancer. And over 20 is really quite concerning. When we diagnose prostate cancer with a biopsy, we'll do some studies. Invariably, when we're first diagnosing it, it's stage 1 or stage 2. If you're diagnosed with stage 4, that means it's already spread into the bones or other organs, maybe lymph nodes. Stage 3 would be sort of spreading into the bladder, neck, and seminal vesicles. This is actually a really important number. So people will ask me, oh yeah, my PSA was 10 and I have cancer. Well, what I want to know is, well, the biopsy you had, was there a Gleason score? Do you remember if it was 6? And somebody say, oh, it was only a 6, and it turns out it was a 9, and that's a big difference. So when we have a PSA of 6, this is a Gleason score of 6 and a PSA of less than 10. That's a patient who we really ought to consider just observing and not actually recommending a treatment. So, so these are my last 2 slides. The anatomy, it's probably not appropriate for the group, but so we find prostate cancer. What do? It is completely reasonable to just watch the patient. Let's follow the blood test. Let's make sure we're okay on the scans. Maybe we'll need an MRI. Maybe we'll end up doing another biopsy to be sure. Based on this, if we're just going to watch it, should we even have done the biopsy, or should we even have done the PSA blood test? Prostate cancer is often very slow, and there have been some stories shared here this afternoon where there are loved ones who have really aggressive cases, and I've seen them too. I haven't seen one under 40, but I've seen aggressive cases, and it's hard. And I don't have a personal connection to this, but we don't want to be too aggressive with prostate cancer, because often we're finding it in a 68-year-old who's not healthy, who's going to wind up with some other more serious medical problem and never die with prostate cancer or from prostate cancer and never even have symptoms. Okay, treatment options. Cryotherapy, please don't do it. Freezing the prostate under anesthesia, lots of complications. High frequency ultrasound, it's one of those kind of newest, latest things. We don't know how well it's going to work. It's well tolerated, but we just don't have enough evidence that tells us, hey, this is going to be every bit as curative as the other treatments. We don't do chemotherapy for prostate cancer unless it's advanced. And when we do chemo, it works exceedingly well. So there are cases where, prostate cancer, we had it under control, not so much. Eventually we need chemo. This is not cancer of the pancreas. By father's close friend just died of brain cancer. She was doing fine. She was in the Everglades. She became incoherent. They found a tumor. She was dead in 6 days. That's not prostate cancer. My patient who showed up with a PSA of 4,500 a year and a half, he's walking around and doing okay. He's in some pain, but he's doing okay. So prostate cancer is not the death sentence of others. It's really common, and there are aggressive cases. But being told you may have prostate cancer, being told you may need a biopsy, being told you have an abnormal blood test, this is not something to panic over. Hormone treatment works really well. We want to use hormone treatment with radiation. And I feel like in this community, we're not doing that enough. These are real detailed conversations. I have a bias. I feel like we're in this community. I want to say it might be the rural South, because I don't think this is going on in Atlanta, but I think we're doing more radiation here than we should. When we have a more aggressive prostate cancer, the cure rate is clearly going to be lower with radiation, whether you do a radioactive seed implant, whether you do external beam. CyberKnife, a new real attractive treatment. You just do 5 treatments, really easy. You're in and out, doesn't take weeks and weeks. Is it as curative as surgery? Doesn't matter. Is surgery really risky? You go to a surgeon who has good experience, and I refer to one in particular who's outstanding. And some surgeons do a lot of these cases and they have good results. Some people are going to leak urine. Some people are going to have erection trouble. Some people don't want to live like that, and that's okay. Then they should probably just be watched. Maybe they shouldn't have had a prostate biopsy. But I am seeing a lot of guys who get radiation when maybe they should just be watched, or maybe they actually had more aggressive disease and really should have thought a little harder about maybe surgery. So I apologize for being real blunt about this, but that's what I've been seeing in the practice patterns around here, and it surprises me. I did the seed implant in Connecticut, Rhode Island. It was kind of new back in the late 90s, early 2000s. It really, in New England, and probably in Atlanta too, it's fallen out of favor because the surgery is just so good now. The robotic surgery with the camera, the visualization. Here's a picture when the surgeon, and it's not an easy operation. You need a surgeon that does this all the time. But the surgeon with the camera can identify the nerves. Now, they don't look like this. This is for our benefit. But you're looking under the camera, separating the nerves from the prostate to preserve the blood flow to the penis, to preserve the ability for the penis to have erections down the road. It's not going to be perfect. Some guys will do fine. Other guys, the surgeon says, I did a good job, I got everything. It's not always going to work 100%. But, when we're talking about a curative treatment, maybe that is a treatment that we need to think real hard about. I did have something here called salvage therapy. And what that means is, well, we've treated your prostate and it looks like the cancer came back. The PSA was supposed to go to either 0 or a very low number, and then it started to come up. Well, what else can we do? Not that many surgeons want to take the prostate out after you've had another treatment because the complications are pretty high in terms of injuring the rectum, leakage of urine, some significant complications. So it's not wrong to do radiation. It's not wrong to do high frequency ultrasound, but we really want to do it in the low risk patient, the Gleason score 6, the PSA of 10 or less, a man who's not in the prime of his life. And I don't mean to disparage a very fit 60, 65-year-old, but, that's a patient who, with early disease, I think is a really good candidate for radiation. But the younger patient, 50s, very fit, very healthy, for my money, surgery is going to be it. And this is, full disclosure, radiation has a role, but And I take it personally. I take my patient care very personally. It's not healthy, actually. But, well, that's that. So the chat box is going to take us through 4 o'clock, I'm sure.
Somebody had mentioned, Paul Clark had asked, and I'll get you, Ken. I think Ken has his hand up.
Right.
Urolift. What about the urolift?
Prostate enlargement, separate topic.
Oh, okay. Okay. All right. So that doesn't, it's not having to do with any prostate cancer.
If somebody says your PSA is high, why don't we do a urolift and then we'll check out your prostate, find a new doctor.
Okay.
I've seen it. Don't laugh. I've seen it and I don't like it.
Okay. Good, good. Ken, you want to go ahead?
Yeah, I'm because I go to church, and I was gonna say I was diagnosed with prostate in 2010, and they've been watching. I had almost 9 biopsies and everything. They was watching it, but then I started getting urinary problems. Well, before then, I got tumor in my kidney and my liver, and they had to take it out, take one of my kidneys out, so I have to get healed from that. But then what I was gonna say is that what happened was I started having urinary problems. And so it gave me a Roto-Rooter, doctor knows TERP. So I got that, and they said the cancer been stirred up in your system. You got to do something. So I went and got proton therapy. That's expensive. The normal person can't get that. You have a little money. My co-payment was $10,000. I had to pay it. I'm telling you, now, there's stuff out there for. I got my best friend. He had the robotic, and he's doing well. He's doing fine. So it's the choice that you wanted to make. But if you got it, if they tell you to make a choice at a certain time, but I will watch it if it's slow. Because like you said, my doctor said, you die from something else before that, heart attack or anything else before then. That's all I want to say. I'm Ken Farley, and I'm doing well. I finished my treatment, my proton therapy treatment, and I paid it off too, yeah. So I'm good now, and I tell you, I feel 100% better.
Ken Farley is also a veteran. He's a family member of mine. So I asked him to come on, kind of give a testimony. So.
Yeah, second cousin. I'll let you know, second cousin. I can come back to church. But I want to say anything else you get on, let me know about it, man. I tell you, if you had to get the test with the finger, which one are you gonna do? You gonna get it done or die? That's all I can say.
Thank you for sharing.
Okay, talk later. Bye.
Anybody else with any other questions? I know Eddie.
Okay, I'll ask a quick one then. I've been told that the Flomax increases your PSA level also. Can that take it into the danger range or the suspicious range?
Not at all. That's false. Flomax
Okay.
should not impact the PSA. PSA can fluctuate. It doesn't reliably fluctuate based on a recent rectal exam, bicycle riding, sexual activity, the lack thereof. We don't know why the PSA fluctuates. It's pretty aggravating. But no, the only thing that will lower the PSA is finasteride or dutasteride. That's not a good reason to take it. We don't want to treat a number. We're treating a patient. But Flomax is specifically to improve the flow of urine.
Okay, because I was told that, well, the other things you mentioned, I think you mentioned those things also, because some people claim that if you do it immediately after having multiple orgasms, that it may go up also too. So thanks for shedding that extra light on when to do it, when not to do a PSA, basically.
The young, healthy guy, I don't want to look for reasons not to do a biopsy. And it may sound aggressive, but I think there's a sentiment in the audience that, we want to find this early. And I don't want to be doom and gloom, diabetes, heart disease, cholesterol. There's a lot of healthy things out there that health conditions we have to pay attention to. But the healthy young man, well, I had sex, so let's repeat it. Let's do an antibiotic. I'm not into that. I want to prove we don't have cancer, so we can rest easy. Or if we find it early, let's deal with it.
Just quick. When I read the question, I didn't read it fully. When Paul Clark mentioned about the urolift, he was talking about BPH. So And he just wanted to know, is that recommended for BPH? Sorry, I know we're talking cancer, but I read the question wrong, so that's my fault.
Yeah, the UroLift is popular. It's easy. It mimics the TURP. Your second cousin Ken had a TURP, traditional operation, more invasive, a little riskier than the UroLift, but the UroLift is a pretty good non-invasive procedure. Minimally invasive, excuse me.
All right, good. Anybody else with any other questions? We're at the 4 o'clock mark now.
Thank you for the opportunity, and I admire what you're doing.
Okay, good. One more, I had a nurse friend that had mentioned some of the concerns that we would have as men, and she was a nurse and she was pretty good, but she says usually one of the issues with prostate cancer, we as men worry about erections and incontinence post-prostatectomy. So is that still a major issue with our patients, or with the robotics and everything else, has that been able to minimize or reduce those risk factors?
I never mastered, I never developed an interest in robotic surgery. It's really challenging to get good at it. It takes a lot of experience. I think I can't tell you how many of the surgeons are awesome and how many aren't. I think the best surgeons will have some patients that leak urine, and an awful lot of patients are going to notice erection trouble. To think that radiation won't cause similar complications, or let's say side effects, is wrong. The seed implant, very attractive procedure, but cure rate's going to be lower. Patients are going to have urinary troubles, not as a rule, but a lot of these guys are going to have burning and frequent urination. Radiation has a role, but even though I performed the seed implant, I'm really not a proponent of it. I think it's fallen out of favor because robotic surgery has gone just so well. So, you know, it's a roll of the dice when you want to have surgery. Am I going to wind up wet? Is this going to ruin my quality of life? There are people who say very honestly, I don't want to deal with it. I just as soon watch it or deal with whatever the consequences. And, you know, you got to respect that. But no, they're heavy discussions.
Okay. One last question. Somebody had mentioned here, after surgery, what should the basic range of your PSA be? And I think you mentioned it, but I don't know whether it's just it varies.
Yeah, it's almost like I don't want to cherry pick people here. If you have low risk disease and your PSA is 0 after surgery, you're not cured, which is pretty awful, but prostate cancer is so slow. We really have to keep a close eye on it. Sometimes you'll get a recurrence in over 5 years. With radiation, we don't expect the PSA to go down to 0. It should go down, ideally less than 1. It should stay there indefinitely. It can fluctuate a little bit. That can make it unnerving, but it should get down to a low level and stay there. There are plenty of people get cured from radiation. I feel like I've been maybe a little too negative about that treatment, but
all right, that's good. No, I don't think you've been too negative. You're giving your professional experience too. And things change in medicine, and Dr. Carrington will mention this too. In medicine, things have changed so much over the past just 10 years, 20 years. So you've got certain procedures and medication and that sort of thing. One last question, and I'm going to ask Carlo, and you can close with prayer, Carlos.
All right.
Whether hold on a second. I don't know whether Southern is on, because he might be able to give the next topic for next week. But go ahead, Carlos.
I will, Kenny. I will at the end.
Okay.
All right. Doc, I have been listening, and I wanted to ask about the prostate and, well, what I thought was an obvious correlation between the prostate and ED. And what impact does the prostate have on, how should I put it, the plumbing not working right?
I just realized I left something out that I think is worth talking about, and you'll have to indulge me. We'll talk about ED in about 20 seconds. We still have a big audience.
Sure.
I'm really concerned about the rampant use of testosterone. I'm really worried about it. Testosterone will increase the cholesterol levels, blood count, risk for stroke. When taken orally, we'll see liver disease and even liver cancer. And then there's the prostate. Will taking supplemental testosterone cause prostate cancer or prostate enlargement? We don't know. We really don't. But Kenworth and I were about the same age, I think, and we went to med school. And other audience members, forgive me. The dogma was women who are postmenopausal needed Premarin to prevent heart disease. Well, they were wrong. We're going to see in the next 10 and 20 years a real clear evidence of the negative impact of our country's desire to be muscular, and it really sickens me and worries me. But you asked about something entirely different. You asked about erections. Erectile dysfunction is most closely related to blood pressure and diabetes, and those conditions not being well controlled. We also see this with medication side effects. Erectile dysfunction is not necessarily associated with prostate enlargement. There's and the treatment for prostate cancer, and to a certain extent the treatment for prostate enlargement, will impact a man's sexual functioning. So whether it's a medicine we prescribe, a treatment for prostate enlargement, the hormone treatment, the medicine to shrink the prostate. I like alfuzacin, I mentioned, for benign prostate enlargement for a weak urinary stream. It doesn't affect the orgasm. It doesn't impact the erection. But yeah, I wouldn't say that erectile dysfunction is a risk factor for prostate cancer. I wouldn't say that at all. I would say it's a more likely a risk factor for underlying vascular disease.
Okay, good.
I'll
We'll have you close with prayer, but let me have Marcel mention what's next for next week. And
So, Dr. Robert, thank you very much. You have informed us. Thank you for the information that you've shared with us today. Today has been one of our largest audience that we've had in quite a while, and I think it's testimony to the value of the information that is needed and that you have shared with us today. Next week, we're going to be having the great Edward T. Goodman III sharing with us. Eddie, if you're still on with us, you have any ideas as to what you'll be sharing with us next week?
Not quite sure. I'm going to be looking at getting a guest, but I will post that as quickly as possible in the chat so that everyone will know.
Okay, thank you very much, Eddie. And we, again, today was the first time that we broadcast live on YouTube, and we had a good following there also. So thanks again, Dr. Robert, and we look forward to having you, because I'm sure you have not exhausted all the areas that we need to pay attention to.
Well, thank you very much for the opinion and for the opportunity. I enjoyed it.
Thank you. Over to you, Kenny.
well, I just want to thank my friend and colleague, Robert, very much. I keep saying Doc, and he says, no, call me Robert. But thank you very much. This wasn't easy. I'd asked him a couple of weeks ago, and he pulled things together. So he did an excellent job. And you guys have any other questions or anything in our group chat, you can mention it. I can relay the questions to him and see whether he can get some answers for you. So
And Kenny, just wanted to mention again, whatever information you got here today is not medical advice. Please go to your doctor and do not say Dr. Robert said. You can ask the question, but it is not, you were not given any medical information for you to act on today. All right, I just want to make that very clear, because I don't want to hear anyone said, oh, but we learned on Friends Talking this. Please consult your physician and walk them through your concerns. If you hear an idea that you want to explore, you can do that, but let it not be said that Dr. Robert advised you to do this. Okay? Thank you very much, Kenny.
Is that why he said call him Robert and not Doc? I'm just asking.
The lawyer in you, Carlo.
I just play one on TV.
Thank you.
Well, I should go ahead and pray now, Kenny?
Yes, you can go ahead.
All right. Well, gentlemen, let us bow our heads in thanks. Heavenly Father, we want to thank you so much for the privilege of having Robert, who is not Doc, with us today. We're thankful, Lord, that he has shared with us these gems, all this relevant and pertinent information that certainly will positively impact our lives. Certainly for me personally, Lord, I'm grateful that he came on, because I now have to go and spend some money and speak to my doctor. But I'm thankful, Lord, that you continue to provide persons of learning so that we can benefit, so that we can make our lives better. And in making our lives better, we can be of greater service to our fellow men. It is not lost on us the need to give back, to always be generous in our abilities. So thank you, Lord, that Robert has been exactly that. And we pray, Lord, that you'll bless him and continue to guide us all. In Jesus' name we pray. Amen.
So, Carlo, make sure you get that plumbing checked out, all right?
Yes, sir.
Thank you again, Dr. Robert. Okay, guys, have a good one.
Yes, indeed.
Bye-bye.
Bye.
Bye.